Hello, my name is Dr. Michael Miao. I am a partner of the Desert Orthopedic Center in Las Vegas, Nevada, and the Director of Sports Medicine in the Department of Orthopedic Surgery at the UNLV School of Medicine. At the time of the production of this video, we are in our third year of the residency, and teaching the exam has revealed to me that there is a wide interpretation of what the various tests are and how they are performed. This video will present the physical examination that I have used in my 21 years of practice. Its purpose is to aid medical trainees in understanding the various elements of the physical examination, its implementation, and a suggested pattern of flow that is concise and comprehensive in nature. While I recognize that there are a great many examination techniques that have been described, this exam does not attempt to incorporate every one. The intent is to have a reasonably complete exam that will capture most diagnoses commonly encountered in the clinical setting. This is the second video in a planned series of educational videos meant to facilitate the training of medical students, residents, and fellows. The subject of this video is the physical examination of the shoulder based on an accumulation of experience in treating sport-related shoulder injuries. Over the last 22 years of practice, I have been teaching an evolving shoulder examination to medical and physician assistant students, family and internal medicine residents, and orthopedic residents at UNLV. To this day, I still find interesting things about the shoulder exam that challenges me to continually update what I do, the greatest portion of which is the role of the scapula in shoulder complaints. This is something that was never taught in my training, and my suspicion is that it continues to be overlooked by many. Thank you to my sons Jared and Ryland for their assistance in producing this educational video. As with the knee exam, this shoulder exam video presented involves the basic elements of the physical examination that I use. There are certainly more examination maneuvers that you can employ to provide a deeper investigation of the clinical issue. There are some elements of this examination that are beyond the ability of certain patients to accomplish. Using this framework, make judgments of what you and your patient can use of this examination pattern to generate clinical information. The intent of this examination pattern is to provide a concise and comprehensive framework of information that the clinician can use in a reliably repetitive fashion from patient to patient. Keeping a format helps to organize one's thought processes in formulating a running differential diagnosis as the exam progresses. In the reasonably agile patient, this examination can be accomplished in about 2 minutes. For the primary care clinician, it is hoped that this helps streamline your assessment of the musculoskeletal complaint in consideration of the multi-organ system world. This is not the expected physical examination for the acutely traumatized patient. Inspection, palpation, and, if available, radiographs would be more appropriate in the setting of acute trauma. It is important for males to have their shirt off and for females to have a gown and bra or some form of tank top or exercise bra. Good access to the front and back of the shoulder visually and for palpation and provocative exam is important. Simultaneous examination of the contralateral shoulder is also helpful when possible. This examination, as mentioned, borrows many described examination techniques. There are, however, scapular examination suggestions presented here that are not based on any specific peer-reviewed literature. They are based more on simple observation and correlations to specific complaints. I've expanded the use of and my interpretation of exam techniques to aid me in diagnosing and explaining the source of pain and other symptoms in varying presentations. I will attempt to explain them in this video presentation. It is important to conduct a thorough history that includes the time of onset of pain or injury, a thorough detailed description of the mechanism of injury, details of any treatments rendered, and the course of events including changes in symptoms after any or all phases of treatment received to date. I position the examination table away from the wall to allow for full visualization of the shoulder from both the front and the back. For males, the shirt is off. For females, a gown over a bra works well or can be replaced with an exercise bra or tank top that allows for easy visualization of the entire shoulder. Have the patient sit on the examination table and look from the front for any asymmetries of the position, muscles, or bony prominences. I also look for the head alignment to the torso. I then look from the back and observe the same. Look for scoliosis first to see if there's any reason for shoulder positional asymmetries. Look for atrophy of any muscles, particularly the supraspinatus and infraspinatus muscle fossas. For all patients, I palpate posteriorly a specific pattern. I first palpate the position of the superior medial angle and note any changes from normal symmetry. Protraction, elevation, droop, or winging is noted. I then palpate the neck, followed by the trapezius. It is important to note any muscle knots, contractures in the trapezius. This may happen primarily with use or as a compensatory overreaction to weakness at the level of the mid to lower trapezius or rhomboids. Palpate the medial scapular border to the inferior scapular angle, the lateral border up to the quadrilateral space. Palpation of the supraspinatus and infraspinatus fossa can be helpful to localize tenderness as well. Depending on my expectations on the ability of the patient to move easily or with difficulty, I might have the patient reach upward in elevation to watch the scapula move. I do not want an acutely painful person doing excessive amounts of reaching. If I do have the person reach up, I am looking at the elevation of the lateral scapula with the scapular spine and the acromion. I am also looking at the rotation of the body and superior medial angle toward the axis. Another thing to watch for is winging of either the medial border or the inferior angle as the arm is lowered. As I move to the front of the patient, I ask the patient to range the neck in flexion, extension, left rotation, and right rotation. If I'm suspicious of a cervical issue, I will perform a Sperling's or Apley's test at this point. As well, I can evaluate the upper extremity dermatomes, biceps, triceps, and brachioradialis reflexes, and a Hoffman's reflex by flicking the tip of the middle finger, observing for a flexion reflex of the index and thumb tips. Next is the palpation of the anterior shoulder. Start at the sternoclavicular joint and move along the clavicle. I teach my trainees to then use 3 fingers to align along the borders of the anterior, lateral, and posterior acromion. I place a finger at the junction of the clavicle and scapular spine. This V space is the posterior aspect of the AC joint, and I then directly palpate the AC joint. It is interesting how inaccurate palpation of the AC joint can be when I have my surgical residents mark out the bony anatomy prior to start of surgery. The next part of anterior palpation is the coracoid. Medial to this is the pectoralis minor, inferior is the takeoff of the coracobrachialis and the short head of the biceps. Moving directly laterally is the lesser tuberosity. I hold the patient's hand and make sure they are fully relaxed. External rotation of the shoulder helps with palpation of the lesser tuberosity. Then position the arm at about 10 degrees of an internal rotation to palpate the biceps groove. If you toggle the hand between internal and external rotation, you should be able to palpate a sulcus between 2 prominences. The further lateral prominence is the greater tuberosity. Anterior fiber tears of the supraspinatus are very common and are going to seem more like a biceps groove tenderness, but can sometimes be separated out if you really attend to the shape of the groove as it transitions to the greater tuberosity. Reach out to the deltoid insertion to see if there is any direct tenderness there as opposed to just referred pain from the shoulder. At this point, I check for range of motion. I personally do not separate out forward flexion and abduction. I am mostly interested in the functionality of the shoulder to elevate the hand upward. If not symmetric, I use a goniometer or estimate the range of motion. In the sitting position, I use the lateral border of the scapula as my reference point. I do not do this in the supine position to measure to 180. The way I measure it is commonly going to give me about 150 to 160 degrees measured. Symmetry or lack thereof is important to me. If you do ratings and legal assessments, you may be required to measure motion in specific manners. Next is abduction with external rotation. Next is adduction with external rotation. And finally, I use internal rotation among spinal levels. L4 is the iliac crest. I estimate from there. When I am suspicious of a posterior capsule contracture, then I measure abduction with internal rotation. Muscle testing is performed next. Abduction resistance for the deltoids is tested. Supraspinatus testing is in the position of scaption, which is in line of the scapula and makes a V-shaped position of about 30 degrees horizontal abduction from the midline. Thumbs up, which is full can, or thumbs down, which is empty can position, can be tested. I have done both for all my patients for a number of years and have found no difference that helped me clinically. The anterior supraspinatus fibers are then separated out with arms forward flexed against resistance. This is revealing if weakness or pain occurs only in this or a slightly adducted position. Drop the elbows to the side and resist outward rotation to test the external rotators infraspinatus and teres minor. Then reposition your hands toward the midline of the patient's hands and have them pushed together to test the internal rotators. While this is both the pectoralis and the subscapularis, the pectoralis is considered much more powerful in this position, and the subscapularis is not reliably tested here. Biceps upward resistance and triceps downward resistance is tested here. If you have cervical concerns or something more distal, I add wrist flexion and extension muscle testing and testing of the ulnar nerve with intrinsic finger abduction, radial nerve with MCP extension, and the median nerve with DIP thumb and index O sign. At this point, I start with provocative testing for specific pathologic issues. Near forward flexion in internal rotation and Hawkins with additional adduction should create anterolateral pain with impingement. Continue to full adduction from the Hawkins test to compress the AC joint for AC arthritis. Impinge the coracoid for subcoracoid impingement, or stretch the posterior shoulder for muscle irritation and look for localization of pain at one of these areas. In this adducted position, have the patient completely relax and support the scapula with your other hand. Posteriorly load the joint in a posterior apprehension test and observe for response. Then bring the elbow posteriorly with your supporting hand thumb on the posterior glenohumeral articulation and observe if the humeral head is dislocated posteriorly and then reduces anteriorly as the elbow is brought back to confirm a jerk test and a diagnosis of posterior instability. Lower the arm down to the side and test for a sulcus sign with one hand stabilizing the scapula and the other pulling on the arm. Keeping the scapular hand in place, the other hand is used to grasp the humeral head, load it into the glenoid, and push anteriorly for an anterior load shift, then posteriorly for a posterior load shift. Observe for translation, pain, and possibly a labral click to contribute information regarding shoulder laxity and the presence or absence of multidirectional laxity and a possibility of a labral tear. I then hold the patient's hand and ask to supinate the hand against resistance with the elbow flexed to test for Jurgensen's. I then pull the arm upward and ask the patient to hold the arm in horizontal forward flexion to resist and test for speeds. Fully internally rotate the arm and adduct horizontally about 20 degrees to test O'Brien's, also known as the active compression test. Weakness, pain, or a pop would signify a slap tear. External rotation should extinguish that pain or weakness. If there is more lateral pain or more general weakness in this position, consider the anterior supraspinatus as the source of pathology. Guide the palm to the belly and hold the elbow in the same coronal plane. Have the patient press on the belly and test for weakness or attempt to drop the elbow posteriorly to indicate a subscapularis tear. Then place the hand on the shoulder and have the patient press downward against resistance as a bear hug to evaluate the superior fibers of the subscapularis for tear. At this point, I make another look anteriorly and posteriorly to see if the position of the shoulder and scapula have changed. I will also have the patient elevate and lower the shoulder while viewing posteriorly to observe the dynamic motion of the shoulder and scapula. If there is malposition, I will manually correct the malposition and retest. If there is an improvement or resolution of symptoms with this manual maneuver, I make note of that. Although it is not in the scope of this video to demonstrate different maneuvers, it is important to recognize what the pathological motion is and negate that motion to see if symptoms change. If the history warrants, the patient is placed in the supine position to complete the instability assessment. Posterior apprehension is done first with cross adduction and posterior load as done in the sitting position. Then we place the patient in the abducted external rotation resting position in the position of their comfort. Then we apply a apprehension test, was followed by a relocation test, and then a surprise test. Observation and inspection, front and back, resting and dynamic motion of the scapula. Take a quick look anteriorly for the symmetry and then posteriorly as well. If the history supports it, have the patient elevate his arms and look for symmetry and position. Palpate posteriorly the superior medial angle position. Then palpate the neck, trapezius, superior medial angle, medial border, inferior angle, lateral border, quadrilateral space, then the supraspinatus and the infraspinatus. Superior angle, neck, trapezius, SMA, medial border, inferior angle, lateral border, quad space, supraspinatus, infraspinatus. Cervical examination with range of motion and, as needed, Sperling's, dermatomes, deep tendon reflexes, and Hoffman's sign. Palpate anteriorly the SC joint, clavicle, acromial borders, the AC joint, coracoid, and as needed, the pec minor, coracobrachialis, and short head biceps, lesser tuberosity, biceps groove with the long head biceps, greater tuberosity, and the deltoid insertion. SC, clavicle, acromial borders, junction, AC joint, acromion, scapular spine, coracoid, lesser tuberosity, bicipital groove, greater tuberosity, deltoid insertion. Range of motion, elevation, abduction external rotation, adduction external rotation, internal rotation, and as needed, abduction internal rotation. Elevation, abduction external rotation, adduction external rotation, internal rotation. Muscle testing, deltoid, supraspinatus with full can, empty can, and anterior fibers, external rotators and internal rotators with biceps and triceps. Deltoid, supraspinatus full can, empty can, anterior fibers, external rotators, internal rotators, biceps, triceps. Provocative testing with Neer and Hawkins for impingement, adduction for AC joint compression or subcoracoid impingement, posterior apprehension and jerk test for posterior instability, sulcus and load shift for laxity, Jurgensen's and Speed's for biceps, O'Brien's for slap and possible supraspinatus, and belly press and bear hug for subscapularis. Neer, Hawkins, adduction, posterior apprehension, jerk test, sulcus, load shift posterior and anterior, Jurgensen, Speeds, O'Brien part 1, second part of O'Brien, belly press, bear hug. Recheck front and back, resting in dynamic motion of the scapula and manual correction of the scapular malposition. Okay. Observe scapular rotation and arm symmetry with elevation and lowering. Next will be a video presentation of the entire exam. Anterior, posterior, SMA, neck, trap, medial border, inferior angle, lateral border, quad space, neck flexion, extension, rotation, rotation. SC, clavicle, AC, trap, your coracoid, lesser, bicep, greater, deltoid, elevation, abduction external rotation, adduction external rotation, internal rotation, deltoid, supraspinatus and scaption, full can, empty can, anterior fibers, external rotators, internal rotators, biceps, triceps. Provocative exam, Neer, Hawkins, adduction, posterior apprehension, jerk test, sulcus, load shift posterior and anterior. Jurgensen's, Speeds, O'Brien Part 1, O'Brien Part 2, belly press, bear hug, posterior repeat exam, dynamic scapular motion, elevation and lowering. Manual crushing, repeat the elevation and lowering. The instability examination is continued in the supine position, particularly for the safety of the anterior unstable patient. The arm is brought into a cross-adducted position with a posterior load, with the opposite hand supporting the back of the humeral head. The arm is then placed in the abduction external rotation position in the patient's position of comfort, and that can be measured for range of motion. We then place the protective hand on the humeral head without pressure, advancing the hand in external rotation, generating a anterior apprehension load. The supportive hand is then pressed downward on the humeral head to support and reduce the humeral head, and then is slightly lifted for a surprise test for reproduction of symptoms. In this normal setting, posterior apprehension, resting abduction external rotation, apprehension anterior, relocation, surprise, and then reduce. Next is a simulated response if positive for anterior apprehension. Posterior apprehension, resting abduction external rotation, apprehension, anterior, relocation, and then surprise. I would like to go over some basic scapular reminders. It is a floating bone surrounded by muscle. Deep to the scapula is the serratus anterior and the subscapularis. Medially is the rhomboids and the trapezius. Laterally, supraspinatus, infraspinatus, teres minor and major. Anteriorly, you have the pectoralis minor, coracobrachialis, and the short head of the biceps. And the glenoid is a detachment area for the long head of the biceps. It is also connected to the axial skeleton via the clavicle and the AC joint. It glides and rotates over the rib cage. Optimal balance of the muscle forces allows for normal resting position. Motion and scapular relationships include reaching forward, which involves scapular protraction, reaching upward, which requires scapular rotation and elevation of the acromion, a shrug, which includes scapular elevation, and reaching laterally, scapular retraction. There may be various mixed combinations of these independent motions. Examples of scapular dyskinesia include upper trap contracture with tightness, which is a very common problem in office workers and people who use computers for extended periods. This results in elevated superior medial angle, restriction of the rotation of the scapula with arm elevation, and a relative downward tilt of the acromion. Scapular droop is an example of upper trap weakness with its also a downward tilt or position of the acromion. Winging can affect the medial border, which indicates a serratus anterior weakness, or can involve an inferior angle winging, which allows dorsal or upward tilting of the scapular body and a relative downward tilt of the acromion. Protraction involves rhomboid weakness, resulting in a relative downward tilt or forward projection of the acromion. As the scapular body is moved, the coracoid position also changes, affecting the position and attachment of the pectoralis minor and the biceps and coracobrachialis. In this illustration, you can see as the trapezius pulls the superior medial angle upward, the acromion necessarily has to rotate downward, which increases the potential for pressure on the greater tuberosity in the elevated position. This would result in increased pressures in the subacromial space and as well on the rotator cuff. In scapular droop, the upper trapezius or the levator scapula are deficient, resulting in a lower position of the scapula and a lower position of the acromion, again resulting in higher pressures in the subacromial space during arm elevation. Scapular winging can occur in two basic directions. One is inferior angle winging, which results in a downward rotation of the acromion toward the rising greater tuberosity in elevation. The second is medial border winging, which forces the acromion forward into the rising greater tuberosity, again in the elevated position. The position of the greater tuberosity in relative rotation or abduction in that elevated position will determine what aspect of the rotator cuff receives the impinging forces. Scapular protraction results in a forward projection of the scapular body and resulting scapular spine position in which abduction, external rotation, or adduction, external rotation, can result in the posterior greater tuberosity impinging on the scapular spine. Although less common in my practice than outlet impingement, this posterior impingement on the scapular spine does occur in enough frequency to be looked out for. When reviewing MRIs in this situation, look for edema in the posterior cuff between the scapular spine and the rotator cuff, and as well posterior-based partial or full thickness rotator cuff tears. To briefly review, downward tilt of the acromion increases outlet impingement anterolaterally. Forward projection of the acromion increases posterior impingement on the scapular spine and the posterior acromion. Coracoid malposition can lead into subcoracoid impingement and as well tension on the pectoralis minor and the anterior bicep structures. As always, look upstream to the cervical spine and the brain to look for trapezial related issues in the cranial nerve 11, rhomboids for C5 and the dorsal scapular nerve, serratus anterior for C5, 6, 7 with a long thoracic nerve. And finally, two parting comments. One is, think chicken and egg. Is the scapular dyskinesia the primary problem or is it a secondary problem to something else? And that's what you need to keep looking for, is that primary problem if it is the secondary dyskinesia. And finally, the issues here that I presented for the scapular dyskinesia are basically my opinion. This is not based in objective evidence or randomized controlled studies. They are based on basic concepts of malposition, effect of muscular imbalances, and the secondary effects on tissues that result. And as I mentioned in the knee exam, keep repeating these examinations, get good at it, rehearse them, make sure you understand what you're doing and what you're looking for. And as you practice this test, keep asking yourself, what is my differential diagnosis at this point? And keep modifying that list as you go through the exam. I hope the discussion on scapular dyskinesia piques your interest and makes you want to learn more about it, and encourage creative thinking to keep medical knowledge moving forward. Good luck, thank you for watching, and have a great day.